We'll talk about a very interesting topic, thoracic outlet syndrome. Um, as usual, if you are a patient, you are welcome to watch this presentation, but please make sure you consult with your physician. So, thoracic outlet syndrome is a condition in which there is a compression in nerves, arteries, or veins in the superior thoracic aperture, the pathway from the lower neck to the armpit, also known as thoracic outlet. It is rare. It's estimated to be anywhere between 2.5 to 3 cases per year per 100,000 population in the US. Generally speaking, the thoracic outlet syndrome divided into 3 separate categories. Neurogenic, which is the most common, up to 95% or even more, and vascular, which is venous, slightly more common than arterial. What's important to know here that there is a lot of names, a lot of nomenclature for thoracic outlet syndrome in the literature. So, for example, on this systematic review, look how many terms they used to find articles related to thoracic outlet syndrome. So it's important to keep in mind the variability on the name. So we start with some relevant anatomy. So there are 4 important muscles I want you to know by heart for thoracic outlet syndrome. The first one here is the middle scalene. Here we have the anterior scalene. Here we have the subclavius muscle and the pectoralis minor. So the middle scalene originates from the transverse process of C2 to C7 and insert in the superior surface of the first rib. It functions for laterally flex the neck. It's innervated by the anterior rami of C3 to C8. While the anterior scalene, it originates from the transverse process of C3 to C6 and insert in the superior surface of the first rib. Function flexes, rotate, and laterally flex the neck and innervated by the anterior rami of C4 to C6. The subclavius muscle, as you see here, it originates from the costal end of the first rib and it inserts in the inferior middle third of the clavicle. It helps stabilize and control the mobility of the clavicle during movement of the shoulder, especially elevation. Innervated by nerve to subclavius muscle, which is a small branch of the upper trunk of the brachial plexus. And finally, we have the pectoralis minor, which originate from the anterior third and fourth ribs and insert in the coracoid process of the scapula. It protracts the shoulder girdle at the acromioclavicle and sternoclavicular joint and downward rotate the pectoral girdle at the acromioclavicular and sternoclavicular joint, innervated by both the medial and lateral pectoral nerve. So why they are important? Because if you look at the brachial plexus, it originates from C5 all the way down to T1. And as you see, it leaves between the anterior and middle scalene. Then it goes above the first rib here, below the subclavius muscle, and travel down below the pectoralis minor. And this is just slightly rotated to get an idea how this brachial plexus course. Now, the brachial plexus compression, which is the etiology of the neurogenic thoracic outlet syndrome, has commonly or 3 spaces for compression. The first one is the scalene triangle. The second one is the costoclavicular space. And the third one is the pectoralis minor space. So if we look here at the costoclavicular space, you notice you have the clavicle, you have the first strip, then see where is the subclavius muscle, and see how the anterior and middle scalene insert in the first strip, and between them this neurovascular bundle move. So obviously this is the subclavian artery here. Now, if we look at here, this is the platysma, which is very thin muscle. I removed it, so you have the superficial cervical plexus. I also remove it. This is the external jugular vein. I also remove it. And then here you see the sternocleidomastoid with the two head removed. So underneath that, you see the carotid and the internal jugular. With slight rotation, you see the anterior scalene, the middle scalene, and between them, the brachial plexus. And this is the omohyoid here, and this is the trapezius here. Anatomically, as I said, compression of the brachial plexus can occur at three spaces. The scalene triangle, so compression occur as the brachial plexus travel the space between the middle and anterior scalene muscle and the first strip. Costoclavicular space, compression can occur in the space between the clavicle and the first strip. Pectoralis minor space, the area formed from the pectoralis minor muscle anteriorly and the rib cage posteriorly. So this area is not considered to be part of the thoracic outlet proper. However, entrapment of the neurovascular bundle within this space is included in the etiology of the clinical symptoms associated with the thoracic outlet syndrome. Now, this is the interscalene triangle here, right? So anterior scalene, middle scalene, first strip. And it consists of anterior scalene, middle scalene, first strip, and contains the subclavian artery, upper, middle, and lower trunk of the brachial plexus. The costoclavicular space here and here, made up anteriorly by the clavicle, the subclavius muscle, and costocoracoid ligament, posteriorly by the first strip and the anterior and middle scalene muscle, and laterally by the scapula. And it contains subclavian vessel and mainly artery and the division of the brachial plexus. And here is another illustration. And finally, the retropectoralis minor space, which is located here. So we have anterior to the second through the fourth rib and posterior to the pectoralis minor. And this space hosts the cores of the brachial plexus and the axillary artery and vein. So there are some anatomical findings and some predisposing factors to thoracic outlet syndrome. So if we divide it into musculofacial, sometimes we have a narrow scalene triangle. Sometimes we have an accessory scalene minimus muscle. And sometimes we have also an accessory facial band between these muscles. If we look at skeletal anomalies, we have the cervical rib, which is rare, about 1%. And we have hypoplastic first rib, and we have history of previous trauma, which is quite common sometimes. So you often have a history of previous trauma or repetitive stress injury. So this is why it's also common on athletes who perform repetitive overhead activities, sometimes push-up, and require which is a higher risk of developing neurogenic thoracic outlet syndrome. So what can cause this? The common etiology of thoracic outlet has classified either to congenital, traumatic, or functional. So congenital, as I mentioned, cervical or cervical first rib, or first trip, as you see here. Traumatic history of whiplash injury, motor vehicle accident, functional, vigorous, repetitive upper extremity activities. So how this present? So the most common symptoms are pain and paresthesia. And the key in the history is the positional change. The patient often can reproduce the symptoms, especially the neuropathic symptoms, by certain position. And very less commonly, you can see hand discoloration or swelling and weakness, which is very rare. So here is a small study about 50 patients. They looked at clinical presentation of thoracic outlet syndrome, and they found that 98% they have paresthesia, 92 they have trapezius pain, 76 they have supraclavicular pain, then followed by chest pain, shoulder and arm pain, slightly more common, and even occipital headache can present. And paresthesia to be present, the most common, and that can involve all 5 fingers or the 4th and 5th finger, which is, and sometimes you have numbness and tingling. Here is another study, slightly larger sample size. Notice the median age was 37, and the most common symptoms were upper extremity pain, almost all the patient, exacerbation of symptoms by arm elevation, localized supraclavicular or subcoracoid tenderness to palpation, and upper extremity or hand paresthesia. Now, just to remind you that the most common dermatomal pattern, the T1 and C8. So that's T1, C8, that's most common presentation, which is, as you know, this is the ulnar distribution. Now, when it comes to physical examination, think about broadly 3 things you need to do. Palpation, there are 3 important points, which I will show you in a second. You need to do provocative tests, and you need to rule out common differential diagnosis by doing certain examination. So, the most common provocative test, we have the elevated arm stress test and the upper limb tension test. The most common test you need to do to rule out common differential diagnosis, the tunnel sign and Fallon test for carpal tunnel syndrome, and Sperling test for cervical nerve compression. The Sperling test, as you remember, it's passive cervical extension with rotation to the affected side with axial compression, and it suggests nerve root compression. When it comes to palpation, remember, which makes sense, as I mentioned, the compression can occur in the scalene triangle, so you need to palpate in the interscalene groove. It can occur in the costoclavicular space, so you need to palpate just below the medial border, the medial edge of the clavicle, and it can occur underneath the pectoralis minor muscle, so you need to palpate here, right? When it comes to provocative tests, there is many of them in the literature. So this table summarizes them to you and nicely mention the sensitivity and specificity. I will not go over them all in details because we don't need to, but I will go over some of them in details. So starting by doing provocative test here, the best initial provocative test to screen for thoracic outlet syndrome is the upper limb tension test. Upper limb tension test. Because the negative test suggests again brachial plexus compression. And then you can follow up with elevated arm stress test. Elevated arm stress test to further support the diagnosis. Now, it's important to know that although a single positive provocative test is not enough to diagnose neurogenic thoracic outlet syndrome. A negative upper limb tension test provides strong evidence against the diagnosis of brachial plexus compression. If it's suspected, additional diagnostic tests such as ultrasound, EMG, MRI can be done, which I will cover that in few. Now, here is the most important test based on the literature, which is the upper limb tension test, which is very simple. So first you can do it either while the patient sitting or standing. Maybe sitting is easier. So here you ask the patient to abduct arms to 90 degrees. So you see the arms. And then ask the patient to extend their wrist like dorsiflexion, right? And then the third step is to ask the patient to tilt the head to the right and to the left. Now, what we expect in position 1 and 2, that the symptoms reproduced on the ipsilateral side. While when we do 3, which is asking the patient to tilt the head, usually it's a contralateral side. So for example, here, if this patient has left thoracic outlet syndrome, the patient is tilting the head to the contralateral side. That creates more pain than tilting the head to the ipsilateral side. Well, it will be nice to observe that the pain start with position 1 and increase with position 2 and increase in position 3. So there is a gradual increase. That's even a stronger indicator of a positive test. And we see here I left for you the sensitivity and the specificity of this test. The second one is the elevated arm stress test, or ROS test, which is also simple. So you ask the patient to abduct to 90 degrees with the elbow flexed. So as you see here, right? And then the shoulder slightly externally rotated backward, right? Makes sense. You're stretching more the pectoralis. And instruct the patient to continuously open and close the fist for up to 3 minutes. And then you're going to do 2 things. One, you're going to measure the time in seconds until the onset of symptoms, or the time until the patient is unable to complete because the pain gets so bad. A positive test is indicated by the reproduction of the local or distal pain, which is the neurogenic symptoms. Obviously, the faster you get the symptoms, the worse the entrapment. Now, Addison test is more for vascular, and basically you palpate the distal radial pulse and instruct the patient to abduct the arm to 30 degrees with the arm in fully extension. So then the patient will turn their head toward the involved side and take a deep breath. A positive sign if the radial pulse diminish or disappear and or a sudden pain occur. And as I said, this is mainly indicative of vascular compression. Talking about the subclavian artery here. The other test that can be also done is the Cyriax release test, where the patient can be seated, their arm crossed, as you see here. The patient elbow should be in 80-degree flexion, as you see. The clinician come from behind, place their hands on the patient elbow, like here and here, and lift the shoulder upward, and that can be done up to 3 minutes. So what happened, a positive sign for this exam is re-establishment of pain upon releasing of the position. So you see, when you lift it up, you release the tension, and when you release it, then the symptoms come back. So this is called release phenomena, and symptoms are relieved by the maneuver and relapse when the clinician release the patient. One more test here, the Wright's test or the hyperabduction test, and this is more specific for vascular, and it's very similar to Adson, except that you also elevate the arm as you see, and you watch for the for the radial pulse, right? So as I said, the most common form is the neurogenic, but you also have vascular and arterial. This table summarizes common differences between them. As you see, they are all common on, teenagers or young age, like 20, 30. In general, the thoracic outlet syndrome is more common female, especially the neurogenic. And as you see here, which makes sense, the symptoms mainly nerve related, here mainly vein occlusion, and here mainly artery occlusion. So here you can see some swelling, you can see some discoloration here, while in the neurogenic, it's rarely you see discoloration. It's mainly paresthesia, pain, numbness, and pain. It's very important to rule out common differential diagnosis. So 10 differential diagnoses I want you to keep in mind. Myofascial pain, of course, which is, if you think about it, thoracic outlet syndrome is also a myofascial pain thing. Cervical radiculopathy, mainly lower, like C7, C8, T1. Peripheral mono or polyneuropathy, like cubital tunnel syndrome, like with ulnar entrapment, that can be confused sometimes. Shoulder condition like rotator cuff tear, subacromial impingement, etc. Brachial plexopathy and advanced carpal tunnel syndrome, CRPS, MS, Raynaud, and psychogenic syndrome. So to differentiate, these are like a common differential diagnosis. Advanced carpal tunnel syndrome, the pain mainly in the hands, right? With advanced, everything hurt. But if you dig deep in the story, then patient can tell you, oh, it started with these fingers and these fingers and this side, and you kind of get the sense it's mainly median nerve distribution. And if you do a sensory test, you can find things like that, or muscle wasting in the medial nerve distribution. While the neurogenic thoracic outlet syndrome, tingling usually infrequent, and the key is positional and reproducible. So the patient have that constant pain, but that neurogenic sharp tingling numbness usually reproducible with certain position. And usually it follow the lower plexus distribution T1 and C8. While if you have a lower radic like C8 and T1, there is more like you can feel dermatomal and myotomal distribution. You can have some neck pain, and it's different. Again, the key here, the positional reproducibility. And of course, when you look at the cervical MRI, you can see findings that explain that symptoms. So how we diagnose this, there is actually a couple of attempts made to make this easy. One of them is a consortium for outcome research and education on thoracic outlet syndrome, CORE TOS. They came up with this clinical diagnostic criteria for neurogenic thoracic outlet syndrome. So basically, they have 5 different categories with a total of 14 separate items. And they said if you have upper extremity symptoms which extend beyond the distribution of single cervical nerve root or peripheral nerve and has been present for more than 3 months, have not been satisfactorily explained by another condition, and you have at least one criteria in at least 4 out of 5 categories. So this is 5 categories, right? And you need to have 4 out of these 5 present, and to check the category, you need to have one item from that box. So principal symptoms, you have pain in the neck, upper back, shoulder, arm, and you need to have or a plus minus numbness, paresthesia, and weakness. And then symptoms characteristic, you have pain, paresthesia, weakness exacerbated by elevated arm position or prolonged or repetitive arm hand use or prolonged work on keyboard or other repetitive strain task. And then pain paresthesia radiate down from the arm from the supraclavicular or infraclavicular space. In the clinical history, you have symptoms that start after certain occupation, recreation, or accidental injury. And you have previous ipsilateral, or you have previous ipsilateral clavicle or first rib fracture, or previous cervical spine or ipsilateral peripheral nerve surgery, or previous conservative or surgical treatment for ipsilateral TOS. On the physical examination, you will have tenderness, local tenderness on the areas I showed you, arm, hand, digit paresthesia on palpation over scalene triangle, so you recreate that, and weak hand grip or intrinsic muscle or digit 5. In the provocative maneuver, and here you can also rank how severe the tenderness. In the provocative maneuver, as I showed you, the most important two tests is the upper limb tension test and the elevation or elevated arm stress test. So in 2017, they published this study. They validated their criteria on a bigger sample size. And as you see here, these are really common symptoms. So almost 99% have, pain in the upper neck, upper back, shoulder. The numbness paresthesia, extremely common. And then symptom characteristic also 97% exacerbated by elevating the arm position. In clinical history, 79% they have a history of injury. On local examination, the tenderness, the most common thing. And on the provocative maneuver, both are common. The other attempt was made by the Society for Vascular Surgery to report standard criteria for diagnosis, and that was published in 2016. So basically, they want you to have at least 3 out of 4 of the following criteria. So 1, local finding, very similar. So you have history, consistent, similar, like pain distribution, similar to them. Examination, tenderness, peripheral finding. In history, you have arm or hand symptoms consistent with central compression, the numbness, the pain, paresthesia. Examination, you have that again, the elevated arm stress test and the stress stretch, the up for the brachial plexus, the upper limb tension test, and then absence of other reasonably likely diagnosis, you exclude them. Which is more unique about this criteria is this one here, that the symptoms respond to properly performed injection, which we were gonna go over them. So diagnostic test for clinically suspected thoracic outlet syndrome, you can do chest x-ray just to rule out rare anomalies. EMG, vascular ultrasound, they are non-diagnostic, but they are helpful. The diagnosis mainly clinical. And then imaging and EMG study are helpful, as I said, to confirm the diagnosis, delineate between neurogenic and vascular, and identify the site of compression, and rule out bony anomaly as mainly in the X-ray. So here, plain X-ray, chest X-ray, cervical region can show any anomalies like cervical rip, malunion clavicular fracture, elongated transverse process, etc. Per the 2015 American College of Radiology criteria for imaging in the diagnosis of TOS, ultrasound is a cost-effective tool and visualization of vessel is a strength, but the sonographic diagnosis of compression effect upon the brachial plexus is challenging and may miss regional pathology. Non-contrast MRI can be sufficient to diagnose TOS, whereas MR or CT angio are the best modality to confirm venous or arterial TOS. It's important to note that images should be taken in both natural position and hyperabducted position, where usually trigger the symptoms. Neurogenic TOS is mostly a clinical diagnosis, again, although you can see some edema or loss of fat surrounding the brachial plexus with arm abduction in the MRI. Now, here's an example of ultrasound Doppler. So here you see how nice flow you have in the subclavian artery. And once you ask the patient to abduct 45 degrees above the shoulder, here in B, you don't have any flow. Another useful test can be the arteriogram and the venogram, especially to look for aneurysm or other vascular anomalies or thrombosis. EMG, as I said, it's helpful for differential diagnosis. Even if it's negative, that doesn't mean you don't have thoracic outlet syndrome, but sometimes it's helpful to rule out radiculopathy, carpal tunnel syndrome, etc. And I cannot stress on this anymore. Rather, I just made it like a red. So remember, the neurogenic thoracic outlet syndrome is a dynamic condition in which pathophysiological compression of the brachial plexus usually occur only with arm in provocative posture. So I think whenever you do the EMG, you need to put that arm in that position to be able to better find compression. So how we treat that? The initial treatment always conservative. Data are limited, therefore there is no conclusive evidence that any one treatment method or combination is more effective. Surgery for neurogenic TOS is considered for refractory cases only. Anticoagulation and surgical decompression sometimes indicated for vascular type. So physical therapy, the first line here, and usually start by daily stretches of the muscle that could contribute to TOS. And I'll show you a few exercises here, and modification to daily activities to keep symptoms exacerbation at the minimum. Some suggest avoiding even provocative activities and arm position instead of proposed PT program. So there is a lot of thoughts over that. Postural correction and nerve glides are also utilized to provide some relief in patient. So here in the upper row from A to C, these are stretches for the scalene muscle. As you see, lateral head tilt, head rotation. And here you have stretches for the pectoralis muscle. And here you have scapular retraction. So I will leave this very helpful illustration for you. Now, trigger point injection can be helpful both for diagnosis and treatment. Remember, that was part of the Vascular Society diagnostic criteria. Botox injection can be utilized to treat neurogenic TOS due to muscle hypertonicity. Patient whose compression is due to other causes such as rib, fibrous band, unlikely to respond to Botox injection. Ultrasound guided deep nerve hydrodissection. I think it's interesting, but we only have a few cases. Pharmacological treatment can be helpful. I think mainly the muscle relaxant. You can try NSAIDs, anti-neuropathic pain like gabapentin, Lyrica, duloxetine can also help sometimes. Surgical decompression can be the last resort. Just so you know, when you have a vascular, the duration of symptoms can determine whether you need to anticoagulate, especially because you can develop thrombosis there. Now, let's talk about the scalene block in patient with possible or confirmed neurogenic TOS. So it's not really just the scalene. So the comprehensive protocol should include the scalene, the subclavius, and the pectoralis minor, which makes sense. And even sometimes you can add the levator scapulae and trapezius. And this approach have been studied, and it showed a very high positive rate, 96%. Of course, when we talk to the patient about the procedure, it is extremely important to let them know about the very, very common side effect of inadvertent brachial plexus block, especially the superior trunk or C5 and C6, because they are very close when you inject the anterior middle scalene, and it only need just 1 ml to spill over to the superior trunk, and typically the patient will have weakness in lifting their arm because you affect C5 and C6. So just, reassure the patient and mention that. The same protocol should be used for Botox injection, and it's recommended to limit the dose of Botox up to 200. So don't exceed 200 because there is some case reports of secondary resistance due to developing neutralizing antibody when using larger doses. So when you inject the anterior and middle scalene, so you place your ultrasound probe here. If you haven't watched my brachial plexus lecture, please watch it because this is the interscalene view, and this is the anterior scalene, this is the middle scalene. Now, what's important to keep in mind that inside the middle scalene, you have the dorsal-scapular nerve and the long thoracic nerve. So be careful not to injure them, and you might block them because if you're going to put the medication here, it can spill over. So keep that in mind, and you can also tell the patient that. And if the patient have like rhomboid weakness after that, so you might just block the dorsoscapular nerve for them. If you have serrator anterior weakness, then that's, the long thoracic nerve. Also here, just in front of the anterior scalene, you have the phrenic nerve. So be careful not to block the phrenic nerve. And then the subclavius muscle, it's an easy one. So place the ultrasound probe here in the medial border of the clavicle. So you will see here the pectoralis major, and underneath that here you see the subclavius muscle. Do you remember if you inject medication here, what you can get? Yeah, that's in my lecture in the clavipectoral fascia plane block. So the last one is the pectoralis minor, which is the muscle underneath the pectoralis major, more laterally here. And look for the important landmark, which is the thoracoacromial artery between these two muscles. That's what I have for you. Thank you for watching, and I hope this